Institute at the University of Adelaide.
And I'm Katja Humic, and we will discuss a new model on the formation of the ovary.
It is well known that the ovary arises from the gonadal ridge which develops on the surface of the mesonephros.
The mesonephros is a fetal kidney, which subsequently regresses but contributes ducts to the reproductive organs, particularly in the male.
The origin of germ cells is well known. They arise in the yolk sac and migrate as primordial germ cells through the wall of the developing gut, through the dorsal mesentery, and then laterally to the gonadal ridges and into the ovigerous cords.
There they replicate as oogonia and eventually into meiosis and develop into oocytes. But the origin of the granulosa cells is less clear.
Initially, it was considered that granulosa cells were derived from the rete ovarii, which are derived from the epithelial cells of the nephrons in the mesonephros.
Later it was considered that surface epithelial cells would penetrate the ovary and associate with germ cells to form ovigerous cords. These, in turn, would break down to smaller clusters of cells, giving rise to follicles in which the granulosa cells were derived from the surface of the ovary.
We have published a different model of ovarian development using the cow ovary, which is structurally very similar to the human ovary. The experimental data can be found in this publication, which is freely available.
We will present the new model on formation of the ovary and origins of granulosa cells. We will also present evidence that the development of the ovarian surface epithelium is more complex than originally thought. We will illustrate this development by way of a cartoon.
Let us begin with the mesonephros. It is covered by an epithelium in yellow, with a subepithelial basal lamina shown in brown, separating the epithelial layer from the stroma, shown here in green. Some of the mesonephric surface cells in the location of the future gonadal ridge change their phenotype into what we call gonadal ridge epithelial-like cells or GREL cells. These cells start to proliferate, thus forming the gonadal ridge and the primordial ovary.
The GREL cells continue to proliferate, and primordial germ cells originating from the yolk sac migrate into the developing ovary and replicate as oogonia between the proliferating GREL cells. At this stage, you will note there is not a proper surface epithelium on the ovary, except at its base. This basal area is really mesonephros and it has a proper surface epithelium with a subepithelial basal lamina separating the epithelium from underlying stroma. The remainder of the ovary is composed of germ cells and GREL cells, with no defined surface epithelium at this stage.
Stroma from the mesonephros then penetrates and expands into the primordial ovary. At the leading edge of the stroma is a basal lamina shown in brown. In the stroma are fibroblasts and capillaries, and on the other side of the basal lamina are germ cells and the only somatic cell type, the GREL cells. Note that as the stroma penetrates, it branches, creating areas of the stroma alternating with GREL and germ cells. So in effect, it's this action that creates the ovigerous cords. And again, note that the surface is not covered by a surface epithelium at this time.
Stroma tissue continues to penetrate to below the ovarian surface and it starts to spread laterally. This results in GREL cells on the surface being underlaid by a basal lamina at their interface with the stromal compartment. Occasionally, germ cells also become trapped on the surface by this process. It's about at this stage that the GREL cells on the surface begin the transformation into an epithelium.
Eventually, the stroma completely separates the GREL cells on the surface from the underlying ovigerous cords, and the cords then become closed, whereas previously they were open to the surface. At the medullary end of the cords, The stroma appears to penetrate into the cords, breaking them into smaller groups of cells, again composed of Grell cells and germ cells, with a basal lamina at the interface with the stroma.
The ovigerous cords continue to break down into smaller cords, and the first primordial follicles, containing an oocyte and pregranulosa cells, are formed in the inner cortex medulla region, surrounded by basal lamina. This basal lamina is now referred to as the follicular basal lamina.
At the final stage, the ovigerous cords have been partitioned into primordial follicles, and folliculogenesis commences. It commences first at the medullary end of the ovigerous cords, where they first came into contact with stroma and where follicles were first formed.
The ovarian surface is now fully covered by a surface epithelium, which was initially multi-layered but is now mostly single-layered. It has a subepithelial basal lamina separating the epithelium from underlying stroma. The stroma below packed with collagen fibers. In summary, the Grell cells on the surface have given rise to the ovarian surface epithelium, except at the base of the ovary where there always was an epithelium, and Grell cells that were packaged with oocytes into follicles have given rise to the granulosa cells.
So, to be able to conclude that Grell cells give rise to surface epithelium and to granulosa cells, there is one underlying assumption, namely that the stromal cells always remain on the stromal side of the basal lamina and do not cross it. This is not an unreasonable assumption. You will also note how important the penetrating stroma is to the whole process of ovary formation, including the formation of the ovigerous cords, the surface epithelium, follicles, and the tunica albuginea.
Thank you for listening, and we would like to acknowledge the following.
It was the beginning of our lecture, guys. And the second step, I'd like to show you another point of view. Ovarian tumors. Take a look for the foreign presentation. After that, we will continue together.
Study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today.
Cyst comes from custis, which means pouch, so ovarian sacs on or in the ovaries. They are very common in females of reproductive age, but can affect females of any age. The ovaries are a pair of whitish organs about the size of walnuts. They're held in place slightly above and on either side of the uterus and fallopian tubes by ligaments. Specifically, there's the broad ligament, the ovarian ligament, and the suspensory ligament. And the suspensory ligament is particularly important because the ovarian artery, ovarian vein, and ovarian nerve plexus passes through it to reach the ovary. If you slice the ovary open and look at it, don't try this at home, there's an inner layer called the medulla, which contains most of the blood vessels and nerves, and an outer layer called the cortex, which has ovarian follicles scattered throughout it. Each follicle is initially made up of an immature sex cell or a primary oocyte, which is the female sex cell, and layers of theca and granulosa cells surrounding the oocyte. Now, there's actually loads going on with the ovaries throughout the menstrual cycle, which is controlled by the hypothalamus and the pituitary up in the brain. The hypothalamus secretes gonadotropin-releasing hormone, or GnRH, which makes the nearby anterior pituitary gland release follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. In the first 2 weeks of an average 28-day cycle, the ovaries go through the follicular phase, meaning that out of the many follicles scattered throughout the ovaries, a couple of them enter a race to become the dominant follicle that will be released at ovulation, while the rest regress and die off. All the developing follicles secrete loads of estrogen, which negatively inhibits pituitary FSH, and they also make a few androgens, like testosterone. At ovulation, the oocyte is released into the fallopian tube, and the luteal phase begins, which lasts for the final 2 weeks of an average 28-day cycle. During the luteal phase, the remnant of the ovarian follicle, called the corpus luteum, makes progesterone, which negatively inhibits pituitary LH. If fertilization occurs, then corpus luteum continues making progesterone until the placenta forms. If fertilization doesn't happen, then the corpus luteum stops making hormones after approximately 10 days, becomes fibrotic, and is called the corpus albicans. So as far as ovarian cysts go, there are two broad categories. First, there are functional cysts, which results when the normal cyclical development of the ovarian follicles is disrupted. One type of functional cyst that can form before ovulation is a follicular cyst, which is a dominant follicle that fails to rupture and keeps growing. This can happen if, say, the normal surge of LH that causes ovulation just doesn't happen during a given menstrual cycle. A condition where you might have multiple follicular cysts is polycystic ovary syndrome, which is caused by a dysfunction in the hypothalamic pituitary ovarian axis that causes chronic anovulation, which may lead to amenorrhea or absent menstruation and excess androgen production. Alternatively, if the dominant follicle ruptures but then closes up again after ovulation, this is called a corpus luteal cyst. In this case, the corpus luteum doesn't dissolve, but instead continues to grow. As it grows, the arteries nourishing it can rupture and hemorrhage into the cyst, which is why corpus luteal cysts are also called hemorrhagic cysts. Both follicular and corpus luteal cysts are usually around 2 to 3 centimeters, but they can get as big as 10 centimeters in diameter. They contain a clear serous liquid and have a smooth internal lining, so they are referred to as simple cysts. The last kind of functional cysts are theca lutein cysts. These are caused by overstimulation by human chorionic gonadotropin, or HCG, a hormone that's produced by the placenta, so they're only seen in pregnancy. HCG stimulates growth of the follicular theca cells, so these cysts are usually bilateral, since resting follicles can be found on both ovaries. Theca lutein cysts are more likely to develop when there's more HCG than usual, like when there are multiple fetuses, or with gestational trophoblastic disease, where tumors made up of placental cells cause higher than normal HCG levels. Okay, now the second category of cysts are neoplastic cysts, which is not to say all of them are cancer, but rather that they're caused by the abnormal reproduction of cells on or in the ovaries, which can result in a benign or malignant mass. Broadly speaking, neoplastic cysts are usually complex, meaning that they're larger than 10 centimeters, have irregular borders, and have internal septations, creating a multilocular appearance. The fluid inside these cysts tends to be heterogeneous, meaning there's something other than fluid inside it. Benign neoplastic cysts include endometriomas, which occur in endometriosis, and it's where endometrial tissue from the uterus grows on the ovary. Because they're functionally the same as the endometrium inside the uterus, endometriomas respond to hormones just like the uterus would. Because of this, endometriomas tend to bleed within the cyst cavity during menstruation, and over time they fill up with old, dark blood and shed tissue, hence why they're sometimes also called chocolate cysts. Try not to let that ruin chocolate for you. Endometriomas also release pro-inflammatory factors which cause inflammation, which leads to cyst growth. When they get too large, they can rupture and spill their contents inside the peritoneal cavity. Okay, now let's switch gears and look at ovarian tumors. Since they also have cystic characteristics, they're also included under the umbrella term of neoplastic cysts. First, there's benign tumors. Some originate from surface ovarian epithelium, such as serous cystadenomas, which are often bilateral and filled with a watery fluid, and mucinous cystadenomas, which tend to be multilocular and contain a mucus-like fluid. Some originate from ovarian germ cells, such as mature cystic teratomas, also called dermoid cysts. Mature cystic teratomas are the most common ovarian tumors in young women, and usually contain a heterogeneous mix of mature tissue that comes from 2 or 3 of the germ cell layers. So they can contain fat, muscle, teeth, nails, hair. They're pretty much the Frankenstein's monster of tumors. Yay! Finally, the last category of neoplastic cysts includes malignant ovarian tumors, like serous or mucinous cystadenocarcinomas, which develop from surface ovarian epithelium just like their benign counterparts. Now, there are 3 important complications of ovarian cysts. First, some cysts can become hemorrhagic, meaning there is bleeding inside the cyst. This is more common with follicular and corpus luteal cysts. Second, some cysts can rupture, which will release their contents into the peritoneal cavity. This can be pretty irritating for the peritoneal cavity. Think, for example, of a dermoid cyst with its mixture of tissues like hair and sebaceous fluid. That's not something the peritoneal cavity is meant to handle. Rupture can happen spontaneously, but more frequently it happens after sexual intercourse. A third complication is ovarian torsion, where the ovary twists around the suspensory ligament. Since this ligament suspends the ovary and contains the ovarian blood vessels within it, torsion can cut off the blood supply to the ovary. A risk factor for this is when the ovary is 5 centimeters or larger, which can happen with all kinds of ovarian cysts. Now, many ovarian cysts are asymptomatic. When there are symptoms that include a dull, aching lower abdominal pain around the location of the cyst, dyspareunia, or pain during sexual intercourse, and a feeling of pressure in the lower abdomen, which can also cause frequent urination and bowel movements. If the abdominal pain is sudden, sharp, and severe, that might indicate ovarian torsion, or a hemorrhagic or ruptured cyst. With a ruptured cyst, there may also be low blood pressure or a fast heart rate, and if the blood makes it to the subphrenic space of the peritoneal cavity, which is right below the diaphragm, it may cause upper abdominal or shoulder pain. If the cysts are the result of polycystic ovary syndrome, you might also see amenorrhea and hirsutism, or excessive hair growth on the chin and upper lip, chest, and back. Endometriomas can also cause dysmenorrhea, or painful menstruation, and are associated with fertility issues. Finally, with ovarian torsion, there might also be nausea, vomiting, and a low-grade fever. Diagnosing an ovarian cyst starts with an abdominal ultrasound. If diagnosis is uncertain, an MRI can be done for more information. A blood test for cancer antigen 125 might be done to rule out a malignant ovarian tumor. Ultimately, histologic analysis is the only way to get a definitive diagnosis of the type of cyst, and this is usually achieved by collecting some cyst cells via ultrasound-guided aspiration or following removal of the cyst. Treatment for ovarian cysts varies based on type and size. Many simple cysts will get better on their own. Broadly speaking, if the cyst is under 5 centimeters, observation is usually the mainstay of treatment. This applies to both functional cysts and benign neoplasms like endometriomas, as well as serous and mucinous adenomas. With uncomplicated cyst rupture, when the person is hemodynamically stable, expectant management is also used. They might only be given NSAIDs for pain. If the cyst is over 5 centimeters, it's usually removed by laparoscopy. Surgery is also done for benign tumors that cause symptoms on a regular basis. For malignant tumors, if a cyst is hemorrhaging severely and it's affecting blood pressure and heart rate, or if there is ovarian torsion since lack of blood flow can damage the ovaries. Alright, as a quick recap. Ovarian cysts are fluid-filled sacs on or in the ovaries. They can be broadly grouped as functional and neoplastic cysts. Functional cysts result from a disruption of the normal cyclic activity of the ovaries, and they include follicular cysts, which occur when the follicle fails to rupture before ovulation, and luteal cysts, which is when the follicle ruptured but then closed back up. Particular types of functional cysts are those associated with PCOS, which happen because of chronic anovulation, and theca-lutein cysts, which are only seen during pregnancy when there's too much HCG. On the other hand, neoplastic cysts include endometriomas, serous and mucinous cystadenomas, and mature cystic teratomas, as well as malignant ovarian tumors. Many ovarian cysts are asymptomatic, but when it's symptomatic, a dull aching pelvic pain is common. A sharp, sudden pain could be a sign of one of 3 potential complications of ovarian cysts: rupture, hemorrhage, and ovarian torsion. Small cysts can be expectantly managed, whereas cysts over 5 centimeters that cause complications, or those who appear malignant, should be surgically removed.
So guys, as you see, we need to talk about the tumors of the ovaries, or like you had in the lecture about the cyst of the ovary. Actually, we don't use such a word like a cyst for the present day. If you're talking about any growth inside the cyst or inside the ovary, at the surface of the ovary, we need to use another word, and we will talk about it later. In the beginning, I'd like to tell that ovarian tumors or ovarian neoplasm, what is it? What are that? Are the tumors arising from the ovary? That's all. Ovary is a very serious structure, very big structure. We usually talk about the structure of the ovary like about the uh, like about the thing, like about the stuff which should be consist of just follicles, capsule around of the follicles, and blood vessels inside. No, for the primary view, that point of view is good enough, and you need to memorize it like that. But actually, as you saw in the beginning of my presentation, that point of view is very simple. And actually, inside the ovary, we can find different types of cells, many different types, and numbers of the neoplasm, numbers of the tumors which could be emitted inside the ovary are very big. And no, we need to understand. We need to understand. Benign ovarian cyst, like the most common type of the inclusion inside the ovary, very common, frequent asymptomatic, and often resolve spontaneously. And in accordance with that information, we just know that statistically we can't meet person after 35 years old who wasn't with the cyst before that age. I mean that after 35, all females in the world should be with that or another episode of the cyst formation inside the ovary. Try to imagine how common that cyst could be meted in the world and how often we can meet it in our practice. That's why all of you need to know main information about ovarian disorders and ovarian tumors. Take a look for the statistical information. Да? То есть ovarian cysts occur in 30% of females with irregular menses, 50% of females with irregular menses, and 6% of postmenopausal women. No, it's a big number. Are the big numbers, and you need to understand. Especially if we talk with you about ovarian cancer. Each cyst, each tumor of the ovary should be investigated in a point of view about our thinking about ovarian cancer. Because ovarian cancer is a very dangerous disorder, and we'll talk about it later. What in the beginning, guys? What in the beginning? Why we don't use such word like cyst? Why we don't use such word like cyst? We don't use that word because that word is not very good for us. Not very good for us. What I'd like to show you such picture, like you see the presentation. What are the cyst? Cyst is just an inclusion which could be described like the capsule with the fluid inside. But could be condition when we don't talk about the fluid inclusion inside the ovary. Yes, of course, it can be. And how can we name it? We can name it our solid structure. But it is the inclusion inside the ovary. Yes. Could it be malignant or premalignant? Yes. Could it cystic, cyst, malignant or premalignant? Yes. That's why if we use in our practice just such word like cyst of the ovary, it means that we can not try to exclude some group of the tumors outside from our vision. That's why in a world, best way is to use such words like ovarian tumors to describe each inclusion inside the ovary. And the tumors could be cystic and could be solid. Could be combination of them. Cystic solid tumor. Memorize it. One more time. We can use such word like cyst, but we don't need to forget that that word actually is not absolutely correct. That's why we need to use another words, such word like ovarian tumors. Значит, what else? Ну, one more time, let me show you such story like, okay, a couple of seconds. Such story like structure of the ovary. Structure of the ovary. One more time, take a look for that picture and try to understand that the structure of the ovary is very difficult. Very difficult. But the main inclusion inside the ovary are the physiological inclusions. And what do you know about them? You know that we have two main steps of the life of the each follicle inside the ovary. In the beginning of the menstrual cycle, we can expect for the growth of the new follicle, and the way of that growth start from primordial follicle and finish inside the such structure like uh, Graafian follicle, pre-ovulatory follicle. After that, that follicle should get the rupture. We call it ovulation, and should be formation of the ova from one side and corpus luteum from another side. And actually, if you have no such question like describe what is it ovary, you need to tell that ovary is a combination of the follicles in the different stages of the life of that follicles. No, it will be correct. But if you take just small follicle, you will see many levels of different cells inside. Take external blood vessels, take internal basal lamina, mural, zona pellucida, column, follicular fluid, oocyte. So yes, actually, it's a combination of follicles, but small follicle had a very different cellular structure. And each cell from that follicle can formate abnormal growth. What is a tumor? Tumor is the abnormal growth of primary cell. So, of course, chances to get tumor from the body very high. Why? Because of different risk factors. Actually, pathophysiology of the formation of the ovarian tumors are unknown. It's unknown. But we know that such group of risk factors play serious role. Like different disorders of menarche, history of previous ovarian cysts, history of infertility, history of disorders of menstruation, such a type of information inside the anamnesis of the patient, like smoking, or using of different drugs, specific drugs like tamoxifen. We can talk about such story like using of oral pills, like about that story which can decrease the risk of the cyst formation. Other specific knowledges, guys, and you need to understand that ovary is a factory to produce the egg for fusion with the male gamete in the future. And 30 years, month by month, such changes inside the ovary can formate the risk of the mistakes inside. And one just small mistake inside the one small follicle can formate the abnormal growth inside of that cell. Stable tissue can't show such progressive growth. Unstable tissue, like follicle, which need to work any day during their reproductive life, can formate the risk of the formation. That is why we have risk factors. I believe that you remember the physiology of the menstrual cycle. I don't need to repeat it, but it's a difficult process, and changes inside the ovary could be described with help of your primary information about the menstrual cycle regulation. Don't forget that the ovary should produce hormones. Ovaries should formate the reaction for that to another hormones, and ovary, это такие soft tissues, which can few everything around of them. Так, one more time, let's repeat. Disorders of follicular genesis can increase the risk. Hormonal imbalance, we talk about hormonal imbalance not inside the menstrual cycle, but each hormonal imbalance can make the chances to increase for the cyst formation, tumor formation. Body mass, early menarche, infertility, hypothyroidism, all that stories can permit the increase of the risk of the ovaries, ovarian tumors. How to classify it? Or take a look for the history of the classification. For the present day, we use classification which are formatted in accordance with histological structure. Histological structure. What is the histological structure? Structure of the ovary is different, but we can find there three main points. Germ cells, epithelium in the capsule, and stroma cells. But that three main structure can show most common types of the cyst. If you have formation of the tumor from the epithelium of the ovary, we can name it epithelial cells tumors. If it starts from germ cells, we can name it germ cells tumors. If from stroma, we can name it stromal, sex cord stromal tumors. But don't forget that could be combination, could be other metastatic types, could be non-classified tumors, could be specific tumors inside. Actually, we know not less than 9 groups of the tumors of the ovaries, but the most common of them inside of that 4 groups. And we need to talk, you need to know first, and the main information inside of your mind should be, not like I said, guys, stromal, germ, epithelial tumors, and another one, What you need to understand it, memorize it, and it will be good for you. Each tumor could be divided by 3 big groups, cystic, solid, and solid cystic. How it works? Epithelial cystic tumor, epithelial tumor, epithelial solid cystic tumor, or stromal, sex cord stromal cystic tumor, sex cord stromal solid tumor, like that. And one more thing which we need to understand is the different degrees of proliferation and invasion: benign, oncological, and borderline. I believe that it was easy for you. That's why you need to memorize it. Not very difficult, guys. Each tumor could be benign, borderline, malignant. Each tumor could be cystic, solid, solid cystic. And it should start to grow from one part of the ovary: epithelium, sex cord tumor, and germ cells. Like that. And all of you need to put inside of your diagnosis that information. How can we find information about the structure of the tumor? Very easy to understand it, guys. All with help of microscope, with help of histological examination. And actually, final diagnosis is the result of the histological examination of that or another tumor. In the beginning of our work with the patient with the tumor of the ovary, we can't find correct final diagnosis. And all of us need to remember that we have chances in the beginning of our work to formate our clinical diagnosis like about oncological disorder. And that's the trouble. We need to think about each tumor of the ovary like about malignant tumor in the future. And we can't lose that patient, I mean, from our vision. We need to know it, we need to contact with her, we need to explain it to her that she needs to be with insurance, that she is not with the malignant tumor inside. That's why watching and serious watching is the primary medical tactic in a case if you're talking about tumor of the ovaries. Let's talk about different types of the tumors. We will start it after the small break. Can make a break.